Okay, so it's been a minute or so I think we'll get started and hopefully more people will join us as we continue. But hi, everyone. Thank you to everyone who's joining us today. We're really excited to have Dr. Andrea Andrade here with us. Dr. Andrade is a pediatric epileptologist and director of the Pediatric Epilepsy Program and Pediatric Epilepsy Fellowship Training at Children's Hospital, London Health Sciences Centre. Dr. Andrade has significantly expanded the pediatric epilepsy program with the creation of the Comprehensive Epilepsy Clinic and the Pediatric Epilepsy Surgical Program, providing state-of-the-art care to children with complex epilepsies. We are also very lucky and fortunate to have Dr. Andrade as a medical advisor on the ESWO Board of Directors. So before we begin, just a quick note to our audience members. Please feel free to leave any questions that you have for Dr. Andrade in the comments section, and we will get to as many as we can in the last 15 minutes of her talk for a question and answer period. We also ask that you refrain from sharing any personal medical information. So let's get started and welcome Dr. Andrade.
Thank you, Jamie. This is great to be here and to be part of this amazing webinar organized by Epilepsy Southwestern Ontario. I think in despite of COVID-19 being on our way to get together in person, I think these venues have been incredibly useful to share and spread knowledge about epilepsy and to still getting in touch with our friends from ESW and of course from to all our patients and our group of parents. So today I'm going to share with you a little bit of what are the treatment options for children with epilepsy, especially those that we see here at Children's that have more severe type of epilepsies. And this talk, I have to say, was prepared by me and by myself, but also I have to acknowledge Michelle Gratton, our epilepsy nurse, who has been part of this talk before. So today I'm going to try to explain to you in very simple words what a seizure is. I'm going to explain the different types of epilepsy and what is its relationship with the brain functions. And I'm going to go over the most common treatments for epilepsy in children and why it is important to treat seizures in the first place. So what is a seizure? So a seizure is basically a symptom. It's not a disease. So there's no such a thing of a seizure disorder, of anything like that. A seizure is just a transient occurrence of excessive electrical activity in the brain. That could be involving both halves of the brain, or that could involve a small part of the brain. But the seizure is a symptom and can be occur as a part of the diagnosis of epilepsy, or can occur if somebody, for instance, gets low blood sugar and then they have a seizure, or if they fall, hit their heads, and sometimes they have a seizure. Okay, so it's very important to differentiate the definition of a seizure versus the definition of epilepsy. So now, what is epilepsy? So if we think in simple things that epilepsy could compare of, you can imagine that is like a little electrical storm going on in the brain, okay? And remember also that the brain is not, it's like a network of small cells called neurons, and they are all connected to each other. It's almost like the streets in a city. So if there's a little storm hitting here, it could potentially get larger and then involve the whole area. You can also thinking as a little fires. So if a little fire, like a bushfire, starts here, then it would spread significantly if we don't take care of this initial fire. So epilepsy is basically, and I tell this to all my patients, and some of you may know this because probably heard firsthand from me, is that epilepsy is just somebody who has a tendency for seizures. So that's the basic definition, and it's as broad as saying an infection or a tumor. Could be something incredibly benign that patient may outgrow, or they don't have to really be any worry about it. And we have the other extreme that could be something incredibly severe with and sometimes even cause the death of some patients, and everything in between. which is why we have epilepsy as a condition that can affect anybody at any age and any ethnicity, any gender. So epilepsy doesn't really go specifically for children or for adults. It can happen at any time. And one of the additional things about epilepsy is that it's not just the seizures, as we usually believe. It's also the effect that the seizures may have in the brain. And remember, we talked that the brain is something that is interconnected as almost like a network. So if a seizure or fire is happening, there's going to be some consequences also in the cognition of the patient, so their ability or their intellect, their psychological abilities. So many of our patients suffer from other comorbidities like behavioral issues, autism, intellectual disability, and so on. And certainly the social consequences that my friends from ESW are amazing helping with those. That is trying to get rid of the stigma of seizures and epilepsy in our society, and try to make sure that every family or patient living with epilepsy will have the best chance to be part and as productive of member of society as they can be. So as I mentioned, it's a very broad concept. So I like this slide because it tells you in a very simple way that epilepsy can be very mild and can be very severe and everything in between, okay? So can be something that a child may outgrow, and can be something that responds to medication and doesn't need anything else and cannot have a big impact in development, or can be something incredibly severe that does not respond to the usual medications and may have some severe intellectual disabilities or motor disabilities. So this is the International League Against Epilepsy, for those who are not familiar with, and why would you guys would be. It's a group of people like me that devoted their life to study and to learn about epilepsy. So majority, of course, are physicians, neurologists, pediatric neurologists or adult neurologists who did a specialization in epilepsy, or also are like nurses, like epilepsy nurses, like Michelle, or could be also social workers, dietitians, researchers. So it's basically a group of multidisciplinary experts that dedicate their research, their studies to help and maximize the potential of every single person living with epilepsy in the world. And it's from this group of people that the classification of seizures came up. And why is this important and why we share this with our patients? Is because the patient, it's very important that they know which type of epilepsy have. And it's important to put a name and a last name of the type of seizure that they have. Why? Because different type of seizures may respond to different medications, and also because depending on the type of seizure, we can offer these different treatment options in the sense of potential surgery and things like that. So when we said that a seizure has a focal onset, that means that the seizure may start in a specific area of the brain, and then it's confined. So it's localized to one half of the brain or one hemisphere. A generalized onset seizure is a seizure that may generate from both halves of the brain at the same time. And sometimes we cannot really tease out whether a seizure may be focal onset or generalized onset, and we will have to wait for other testing or other studies or witness of the seizure to tell us more detail to decide whether it's a focal onset or a generalized onset. All seizures are also subclassified into motor and non-motor. And if you see, you can see motor and non-motor in every single category. And motor seizures are not that difficult to figure out, but it's very important for families to discriminate whether a child may have a seizure that is affecting more the right side or the left side, or if it's affecting more the face, because that can give me an idea where in the brain the seizure is originating. Same thing with non-motor seizures. It's very important that the family tells me how long do they last, if the patient is tired afterwards, and so forth, because that can also makes me more aware of whether it's a focal onset or generalized onset seizure. Unfortunately, typically when families experience the first seizure, it's so scary that those details don't come up very clearly to families sometimes. And what they just see is, their child moving all over. And but sometimes when we explain these differences, it's good for us, because that helps us to tell you exactly which type of seizures and potentially which type of epilepsy we're dealing with. Not every seizure is a grand mal seizure, and not every staring spell is a petit mal seizure. Actually, we are trying to get away from those terms. They are very old terms that have been out there for, I don't know, I think from the 80s or something like that. And we are trying to discourage families to use those terms. Again, the non-motor seizures can happen in any of the generalized or focal onset. So saying that your child or your family member has an absence just because they have a staring spell or a moment of being dazed, it's not 100% that case. So it could be also a focal seizure that looks like that. So I also try to encourage families to just describe what they see to me, as opposed to call it, oh, it was like a petit mal, or it was like an absence. So bottom line, not everything that doesn't move is absence, and not everything that moves is a grand mal, okay? So we have to pay a little bit more attention exactly how the seizure starts, so I can tell you exactly where it's coming from. Oh, there were some arrows that I forgot to play. But anyway, so this is a cartoon of the brain that tells you how the generalized epilepsy generates. So this is one half of the brain, this is another half of the brain. And in a generalized seizure, both sides, exemplified by the arrows, are activating the brain. On the other hand, a focal seizure typically occurs in a specific area of the brain. This is one half and this is the other half. And then remember that this is like a branch, or that is like a network. And then it can spread out to different areas in the same side of the brain, or they can even go to the other side as time evolves. So it's very important also to see and to differentiate and to be very accurate in describing the sequence of the seizure for what it's worth. So, and to make things even a little bit more complicated, so if we think about every single function that the brain can generate, or what the brain is actually in charge of, if we can think of all those things, if there is an abnormal electrical activity going on in that specific area, will give you different types of seizures. So for instance, if a seizure is coming from the area where we actually receive the hearing and make sense of what we are hearing every day, like language or sounds or music or things like that, we can have some seizures here that are represented like with sounds, okay? Or the vision area right here in the back part of the brain. If there's an area that is producing a lot of electricity close by, or in that area, the patient can refer to be seeing some flashing lights or some funny shapes in their visual fields and so on. If the seizure is coming from the motor area, then you are going to start seeing the body twitching, the body posturing, and so forth. So again, those symptoms to me are incredibly helpful to pinpoint exactly where in the brain is. And I think it's the beauty of brain concepts, that just seeing what the patient is doing can tell me exactly where the seizure is coming from. So, but the good news about epilepsy is that 70% of cases and 70% of patients who present and are diagnosed with epilepsy are going to be responsive to the first medication that we prescribe. So that means that we receive a patient that has 3 seizures, let's say, as per report, and then we start a medication. Let's say the family is very good describing the seizure. They tell me that they start in the left side, in the hand shakes, and then it goes and affects the other side of the body. We give them a medication, the seizures completely stop. That's 70% of the cases. If not, there's also these 30% of cases that may require a second drug. When a second drug is required, you have roughly 50% chances to respond to the second drug. And if you are unfortunate enough to be in the 50% that doesn't respond to the second drug, then the odds to respond to a third, fourth, fifth are very low, are less than 5%. And we call those patients drug-resistant epilepsy. But not all is like a, like it's not loss of hope. There are some other options of treatments that we can offer to that specific patient population. And the reality is that people like me that have been studying epilepsy for years, our main body of patients that we see and we treat and we offer services are the ones that actually are more difficult to respond. And again, this is the kind of definition of drug-resistant epilepsy is when a patient doesn't respond to more than 2 drugs. And then other therapies need to be considered, and at that point, putting the last name to the epilepsy is very important, okay? And this is a time when the child or the adult patient should be seen by someone who has expertise on epilepsy, not only neurology, but also epilepsy. And for those who don't know, people who are expert on epilepsy, we are called epileptologists. I know it's a big word, but this is how we are called. So how do we treat epilepsy? And again, we have to think about that epilepsy is just more than the seizures. And I like the iceberg concept because seizures are just the top of the iceberg. And you have a brain that is constantly producing seizures, you're going to have certainly in the top of the iceberg the seizures, but also you're going to have affection in learning, and you're going to have affection in behavior, and so on. So it's way beyond the seizures, and I think that's very important to know. Sometimes even ameliorating the seizure can improve learning and behavior. Sometimes these other areas have to also be treated by their specific different therapies, like for instance, counseling, or some patients may even require some medication for mood or for behavioral problems. And certainly if learning issues are a consistent problem, an IEP in school, it's recommended. Again, this is another example just for like as a visual that we have this network of neurons talking to each other. So epilepsy beyond the seizures could have of affecting the areas that prevent us to be hyperactive or aggressive. So if there's an abnormal activity or electricity going on in the brain, the child can also present with some behavioral problems. And certainly also our learning centers are sitting in the brain. So if there are seizures, that can also affect our ability to learn. One very important thing that we don't talk about too much, and we should, and we do it in our comprehensive epilepsy program, is something called SUDEP. SUDEP stands for Sudden Unexplained Death in Epilepsy. And fortunately enough, that doesn't really happen too much in pediatrics. However, certainly epilepsy is not something that stops once you become an adult. And once a patient with epilepsy turns out into adult, the risk of SUDEP certainly increase. And increase mostly in patients who have uncontrolled motor seizures. Okay, either like bilateral tonic-clonic seizures, or focal motor seizures, nocturnal seizures, and so forth. So those seizures are very important to treat early on in life so that we prevent patients from ever experience SUDEP. Unfortunately, this celebrity that was in Disney Channel, Cameron Boyce, passed away from SUDEP in 2019. I think he was not even 20 when he passed away. And this is very sad because these are things that if we spread the word about epilepsy, and if we do our best to offer treatment options for those who have drug-resistant epilepsy, we can potentially prevent. So what options do we have for patients with drug-resistant epilepsy? So and it will depend whether we have a patient with focal onset epilepsy versus a patient with generalized onset epilepsy. So I'm going to start with patients who have focal onset epilepsy because probably it's easier to grasp the idea of what are there for them. So if we find out that there's a patient having seizures and those seizures are coming from a specific area of the brain, sometimes if it's safe, we can take that out and operate on those patients. We have certain different ways to do it. I mean, it sounds very simple when I explain it this way, but it takes us probably like a year or so to do all the specific testing necessary to make sure that a surgical intervention is the way to go for a patient to treat their seizures. But the good news is that for patients who are drug resistant and have a focal onset epilepsy and are good candidates for epilepsy surgery, they have roughly 75% chances of either being cured of their epilepsy or have a significant improvement on their seizures. If the patient is not a candidate for epilepsy surgery, let's say the seizures are coming from a specific area of the brain, but if we take that area of the brain, we're going to cause a problem. We have other options. And we have other options also for patients who have generalized onset epilepsy and become drug resistant. What are those options? One of them is the vagal nerve stimulator, that is like a pacemaker that we implant that helps to treat seizures. And we have some other options. CBD oil is one option. However, there's more and more evidence that CBD oil just works as another type of medication, and it's not the holy grail that everybody thinks, at least in epilepsy. And the ketogenic diet is another option, but not the ketogenic diet that people do in the gym or you know, with your friends. This is a ketogenic diet that has to be verified by a specialist dietitian, a dietitian who is specialized in ketogenic diet. We are talking about children here, so we need to make sure that the diet is their medication, but at the same time, we are giving them enough nutrients and calories to prevent infections and to promote growth and so forth and so on. In terms of epilepsy surgery, we have different types of ways to do surgery in pediatrics, and we'll touch base a little bit about that. We have, of course, all our medications, okay? And remember, medications are our first line of treatment, and that is for any patient that presents with epilepsy. And we have a great number of medications, and we select the medication based on the seizure type and the epilepsy classification. Anyways, for every single treatment with epilepsy, the main goal is no seizures and no side effects. So CBD oil, again, I'm mentioning it a little bit, but who, why, how, and when. And again, it's not the holy grail that everybody thinks it is. So in epilepsy, there's the story of this girl, Charlotte, that unfortunately recently passed away due to COVID-19, which is actually incredibly sad. But Charlotte had a type of epilepsy that is quite severe and also rare, that is called Dravet syndrome, okay? Dravet syndrome is a genetic epilepsy. That means that one of the genes that Charlotte had was abnormal, and that produced abnormalities in her brain that promote seizure activity, and quite severe seizure activity. So back in the day, I think probably like 5-6 years ago, her mom started a campaign in the United States advocating for the use of CBD and medical marijuana in patients with epilepsy. So it's actually her work and her advocacy that made physicians and scientists and epileptologists to actually look at CBD as an option. And initially we did, and now after a few years, there's even a pharmaceutical company that is actually marketing the CBD oil, but that's only available in the US. Now we have data that patients with Dravet syndrome and patients with Lennox-Gastaut syndrome and some other very severe epilepsies may benefit with CBD oil. And the perception of some families is that at times, sometimes can help with behaviors or with spasticity and movement of the arms of some children with a very severe extreme of epilepsy. What are the downsides of CBD at the moment? At least in Canada, we don't have the purified CBD oil product available. We only have dispensaries. And the dispensaries, even if they do a good job trying to purify the product, there's always a little bit of a THC, which is the active drug for recreational use, that is going to be in the bottle. So for children who have Dravet syndrome or Lennox-Gastaut syndrome or very severe epilepsies with some intellectual disability and very frequent seizures, giving them a little tiny dose of THC, it wouldn't really affect their quality of life too much or at all. In those patients, I think it's justified because the benefit is more than any risk. However, in children who have other types of epilepsy, that they go to school, that they play with their friends, that they live in a more interactive life, for those children, CBD oil is not recommended because, number one, again, you don't really, even if the dispensary is a Health Canada dispensary, you never know how much THC the bottle is going to contain. And we have some patients that have gone on their own to look for the CBD oil, and unfortunately, we have some events of transient toxicity with THC, and it becomes very disturbing for the children. They start seeing hallucinations and things like that. So I advise against to go and seek that, especially without consulting with your neurologist or epileptologist, to see if that's something that really fits the problem of your child or the epilepsy of your child. We facilitate the access of CBD oil in patients that are very well selected. And the other downside, of course, is that CBD oil is not covered by any insurance, and families have to buy it out of pocket. And the dosing is the response from seizures is dose dependent. So sometimes to achieve full control is not affordable for families because it becomes very expensive. Oh, forgot to mention before I move out from CBD, because I know there's a lot of questions about this. The product from the United States, the Epidiolex, is, again, it's not approved here in Canada. And the cost is very high. It would cost like 1,500 Canadian dollars a month to get the Epidiolex. And unfortunately, because we have all these dispensaries and we have all these medications, it's very hard to get special access for a medication like Epidiolex to be weighed by Ontario, the Ministry of Health. So that's something that also some families ask if that would be something they could look into. Again, the ketogenic diet is a special diet that basically switches the way we provide calories. Normally, the normal diet of anybody in the Western world is sugar-based or carbohydrate-based diet. What we do with the ketogenic diet is drastically change that carbohydrate-based diet to a high-fat, low-carbohydrate diet. So we drastically change the metabolism. There's some modifications like modified Atkins and so on, but those are still high-fat diets. So again, it's not completely free of side effects. It has some side effects. We have to be monitoring for kidney stones. We have to monitor, of course, for cholesterol and fats getting high in the blood. We have to check the liver function. We have to check kidney function and so on. So it has to have a regular follow-ups with a lot of blood work, but for some patients is a good choice. And it gives you more or less like a 50% reduction of seizures. That's actually the main average of the response from the ketogenic diet, which for some patients is amazing. If they can reduce by 50% the number of seizures that they have, or the severity or the frequency, that sometimes make a big difference in their quality of life. What about the VNS? The VNS is not really brain surgery, although we encompass the VNS in epilepsy surgery. It's not brain surgery. So basically, as I mentioned before, is a small pacemaker that is implanted underneath the chest, and it has a wire. So this is the device, gets implanted surgically in a little pocket that the surgeon makes underneath the skin. And the wires travel underneath the skin, so nothing of this is visible. This is just a diagram, okay? And it gets attached to a nerve that travels in the neck that is called the vagus nerve. The VNS has three main functions. It gives an on and off stimulation that typically goes to the vagal nerve, and that is dosified, and that is actually the anti-seizure medication, okay? And then that has to be actually determined by a computer that we have. We monitor that via the computer, and we increase the dosing also with our computer. So for patients, we have to actually increase the dosing or programming some dosing via computer here in the hospital. The other function that the VNS has is a magnet. The magnet is usually set up for a higher delivery of stimulation compared to the VNS itself. So if a patient happens to have a seizure, that magnet acts as a rescue medication, basically, and they just have to swipe the magnet across the chest, and that would be aimed to stop the seizure when it happens. And that would help families to don't give that much of lorazepam or diazepam to stop the seizure. The third option, the third function that we have on the VNS is something called autostimulation. And what it does is, in an indirect fashion, the VNS actually realizes increases in the heart rate. And when a very sudden increase in the heart rate happens, the autostimulation sends an extra stimulation. Why the heart rate? Because we know that seizures, especially motor seizures, whenever they happen, they cause a very significant increase in heart rate. So the VNS detects that and sends an extra, stronger stimulation to stop the seizure as it happens. Why this is important? This is important, for instance, for patients who have seizures in the night when they are asleep, and they be potentially motor seizures, and the VNS on its own will send the stimulations, and the family doesn't have to be awake, looking at the child, running, trying to find the magnet and going to swipe the magnet. The VNS very likely already sent an extra stimulation for that. Again, the wire goes wrap it up to the vagal nerve. Has some side effects, of course. Nothing is free of side effects. One of them, of course, because the VNS, the vagal nerve is also involved in the vocal cord function. Some patients can have some changes in the voice or some coughing, especially when the VNS is first implanted. Those things can be actually modified, changing the settings of the VNS. If they are intolerable, then sometimes, unfortunately, the VNS have to be stopped. The only reason why we would explant vagal nerve stimulation if there's an infection or something, or a reaction that the body didn't accept the device. That is incredibly rare, but has happened. What about epilepsy surgery? Epilepsy surgery for those patients, as I mentioned. So we have epilepsy surgery that can do in 2 stages. And the first stage is something called invasive monitoring. And we offer these therapies for patients when we are still quite not sure, in the spite of having our MRI, our video EEG, our PET scan, etc. And we're quite not sure whether our seizure focus is more than what we see in our EEG, or if the seizure area is very close to, let's say, the area that controls speech and so on. One way is to put actually electrodes that go directly to the surface of the brain, like these ones right in the left side of your screen. And we connect these electrodes. Of course, these electrodes are placed in the operating room, and then the surgeon puts the scalp on the patient, and then the patient is connected to the video EEG. And then we can identify where the seizure is coming from, okay? This method, the advantage is that this is a one-plane electrode grid, and that gives us the opportunity also to stimulate these electrodes. And we can, let's say, for instance, that the seizures start in the 45 and 46 electrodes. I don't even know if you guys are able to see my cursor. I think you guys are, because yeah. So 44 and 45. And let's say we are unsure whether the speech language is close by. So we can stimulate, let's say, this 36, 37 with a little machine that we have, and see if there's any changes in speech production and so on that tell us whether the speech is here. And we can create a map of where our seizure areas based on this grid of electrodes. The other technique, however, this technique, of course, is an invasive technique. They have to open the skull, they have to introduce the grid on it, and it carries, of course, the risk of infection and some other risks. And of course, we have to be very selective, but that works for some patients very well. The other technique that we have to answer that question is something called stereo EEG. And now we have some robots that actually help our neurosurgeons to do the trajectories of where electrodes are going to be implanted. The electrodes that we use with this ROSA robot are something called depth electrodes, okay? And instead of being like a grid electrode like this, they are basically like big needles, and they are implanted through very small holes in the skull that are called burr holes, and then they get introduced in the brain in different areas that are close by, or the areas that we want to define specifically where the seizures are coming from. We do this testing here whenever we are not sure whether the seizures are, remember that the brain is a three-dimensional structure, and it has mesial areas that look to each other and are very close to each other. And sometimes if we have a focus that is coming from here, in EEG, we're going to probably see something that looks like it's coming from both sides at the same time. So what the stereo EEG helps us to do is to tease out exactly which side of the brain may be the one that is giving us trouble, and help us to localize better that seizure activity. Advantages is that it's a minimally invasive, so they don't have to do a big craniectomy at the beginning, so there's less risk of infection and so on. However, we lose the two-dimensional structure, so in order to do a stimulation we can, but we are going to have some blind spots in between some of the electrodes. Again, the goal for epilepsy surgery is not seizures, not side effects. So we do this with this in mind. So then what happens is that once we find the area that is causing the seizures, whether via invasive monitoring or via other testing, then our surgeon goes there, and then that takes that little piece of brain and then that disconnect the abnormalities, and that gives you seizure freedom again in a roughly 70 to 80% of the cases. In more younger children, or children with a large abnormalities in one side of the brain, especially those who start having seizures very early or have an abnormality that came very early on in life, we do something called hemispherotomy. Okay, I know that it says hemispherectomy here, but we call it hemispherotomy now. And the aim is to disconnect the two halves of the brain that they talk to each other. So what the surgeon do is just go to every single area, disconnecting one side with the other, and then just disconnect the bad side and leave the good side away from the bad side, so the good side can thrive, can actually take functions that were supposed to be doing the other side. And this is called plasticity, brain plasticity, and reorganize the function there without the burden of having a lot of seizure activity. If we leave that for so long, sometimes that can cross the other side, and that can affect the healthy hemisphere. So this is something that we offer usually early on in life. However, even in some patients, if we do an evaluation, we can offer this later on in life. Again, every single epilepsy surgery that we do, even here in London or in Sick Kids or anywhere where we do epilepsy surgery, is a tailored epilepsy surgery, meaning that every case is discussed in detail, and we do every single possible testing to try to answer the question whether it's safe to resect the area and whether that area is responsible for seizures. There's another surgical approach that is called Corpus callosotomy. This doesn't aim to cure the epilepsy, but what it does is we have this big structure here called the corpus callosum. That is the main connection between the two sides of the brain. And sometimes, especially in children who have frequent drop attacks and they fall significantly to the ground, the surgeon can disconnect just the corpus callosum, and that can ameliorate those drop attacks. This is good for children that cannot be hanging out without a helmet, because they fall and they have a lot of bruising and injuries in their faces and in their heads. So that's a possibility for them. Just a word on seizure first aid, and typically we say that the most important thing that happens when a patient has a seizure is to stay calm, to protect the patient from injury, do not restrain the patient, do not put anything in their mouth, and just time it. Just make sure that you have a watch handy, and make sure that the seizure doesn't go beyond 5 minutes, okay? Once a seizure goes beyond 5 minutes, it's an emergency and you need to call 911, okay? So I like this little cartoon right here that is coming from the Epilepsy Society in the UK, and it says, stay calm. So the 3 C's, stay calm, call for help, and cushion the head. So protect your patient from injury, okay? And that's it. We have an amazing epilepsy website. If you guys haven't looked at it, I'm sure many of you, if you guys are part of our program, have looked at it. Have to give credit to Michelle, who actually put together all of us and gather all the information and put it in there, and create a very nice website. I also want to, again, this is not, our program is not the work of a one person, but also a many fantastic group of females, look here, ladies, that work together to fight epilepsy. My colleague, Dr. Nouri, who is also an epileptologist here in children's, Rochelle, that used to be an Epilepsy Southwestern Ontario educator, but now she joined us here in a epilepsy research coordinator role. Bonnie, our shared decision-making coach. Vanessa, who is our friend from Livanova VNS. And you see Val here. Val was with us as a social worker, but now she's gone. But we have a fantastic group of people. So looking after our children with epilepsy here in Southwestern Ontario. I don't know if there's any questions.
Awesome. Thank you so much, Dr. Andrade. That was very, very informative, and I'm sure that was super, super helpful for our families. We do have a few questions, so let's see. Okay, so the first question is, if the VNS fails, then what other options are there to help?
So it depends on the type of epilepsy. If it's an epilepsy, for instance, that has a lot of drop attacks, sometimes VNS and a corpus callosotomy can be the option. Okay, if we are also getting some new research into something called deep brain stimulator. That's a different therapy that is mostly for adults, but there are some groups that are doing that. So that could be a consideration as well. And I think we are in conversations with our friends from SickKids to see if we can send some of our patients to be evaluated for deep brain stimulator if they have failed the VNS and there's no other option for them. The ketogenic diet is another option. So it would depend on the case.
For sure. Okay, well, thank you. Next question is, why do children with West syndrome tend to develop learning disabilities?
That's a good question. West syndrome is an epilepsy very specific for young babies that are around 6 months or so. And they basically have some epilepsy that affects both sides of the brain and a very severe abnormality that is called hypsarrhythmia. So that's bad for the brain, just that abnormal electricity, very chaotic. So depending on the cause of the West syndrome, our approaches are different. But typically our first line would be a specific medication called vigabatrin that is specific being done for epileptic spasms. And in some selected patients, we can also add prednisolone or steroids to help with that. So we still don't understand exactly what's the reason why West syndrome happens. We just know that happens in young babies, like 6 months of age or so. And that's one option. For instance, if the West syndrome is caused by an abnormality on the brain that could be amenable for epilepsy surgery, we sometimes do that. Other option that some researchers are looking into is also the ketogenic diet. So some patients may be good candidates for the ketogenic diet if they are not candidates for surgery, or if they didn't even respond to vigabatrin prednisolone. So we do that for them. But the reality is that very abnormal electrical activity that is called hypsarrhythmia is the one that seems to be affecting the areas that eventually will become areas that help us with learning and cognition.
Right, okay, that makes sense. Thank you so much. The next question is, if an epilepsy patient is on medication but doesn't have full control of the seizures as they occur daily, how is full control achieved?
Sorry, can you repeat the question?
So it sounds like they're asking if someone's taking medication, but they're on medication. So I think you touched on this, but they're taking medication, they still don't have full control because they're still having seizures daily. So how are we going to achieve that full control? So I guess maybe just the other treatment options that you mentioned, perhaps.
Yeah, so we'll have to decide whether the child, again, the most important thing is to put a name and a last name on the epilepsy. And then we can see if any of the other treatment therapies would be a good fit for that specific patient. Right. Again, epilepsy is so broad that I cannot give you a general, specific answer that applies to everybody. But we will have to really understand that specific child, why is not responding. Do we have the wrong diagnosis is the first question. And we have answers to do that. The wrong diagnosis meaning not that the patient doesn't have epilepsy, but that the patient may have, maybe it's on a medication that is good for generalized and they have focal epilepsy. We have to also understand that we are dealing with children. And something that may look generalized when they are little, then may evolve into a focal seizure when they are a little bit older, and it's more clear to see. We are dealing with a brain that is changing just with the child. As the child is growing, the brain is changing. So seizures may be changing, and we may see different things as the time goes by. So epilepsy is not a static condition, especially in children. And actually, that's very specific to children. So we always, if medications are not working, we have to just revisit what we're doing and try to understand why. What I typically do first is try to bring them to the epilepsy monitoring unit and try to see exactly which type of epilepsy we're dealing with. And we are, number one, in the right medication, or number two, if there's a drug-resistant epilepsy patient, may fit in any of the treatment options that we discussed.
Right. Well, thank you. The next question, we have a few more here. It says, if a person has juvenile myoclonic epilepsy, is there a chance of outgrowing it? This started when my daughter was 12.
The problem with juvenile myoclonic epilepsy is one of those epilepsies that may be very responsive to the first medication that we prescribe, but unfortunately it's a type of epilepsy that keeps on going through for the long term. So it's very important that those children have compliance. Again, in epilepsy, we never say never, but the odds of outgrowing is really low. So it's a good idea maybe to evaluate, especially if a patient is super well controlled, to evaluate every 2 years the EEG and see how things are looking at, and then decide. But typically, we always continue seeing activity in the EEG. And when that's the case, it's the risk of having recurrent seizures if we come off medication are very high. So unfortunately, it's one of those that patients may continue to take medication for a long term.
Sure. The next question is, if your child has a problem swallowing, would you have to get a feeding tube with a VNS?
Not necessary. Depends, of course, the severity of the swallowing problem. Okay. Majority of patients with epilepsy who have severe epilepsies, that is affecting the motor system as well. They are going to have swallowing problems baseline. So many of them come already with a G-tube in place. So it would depend how severe the swallowing problem is, and it would depend on the patient for sure. Again, there are some ways to try to minimize any risk of aspiration or anything through adjusting the settings of the device, but sure, it depends on the severity of the reflux or the swallowing troubles that the child may have.
Okay. A few more questions here. So next one is, do they usually have patients awake for placement of SEEG electrodes?
Say it again.
So are people usually awake when they're having the placement done for the SEEG electrodes?
No. That's also a surgical procedure. So even when it's a minimally invasive study, they have to be under general anesthesia in the OR, and then the robot will just tell the surgeon where to drill the really tiny small hole, and then they put the electrodes, but no, the patient's asleep through the whole thing.
Okay, cool. Next question is, when you ask about seizure activity, what's important to you? I find my child has a hard time describing her seizures to the doctors, and it doesn't match what I observe. She's 15.
What is very important is, number one, if the patient has a warning sign. So if the child knows if the seizure is coming, because sometimes that feeling can tell me where the seizures are coming from. For instance, we have some patients that may have, as I mentioned, some visual feeling or some visual phenomena, some little lights going in their eyes, and that tells me that the seizure may be coming from the visual cortex. Or the patient may have like a hearing, little ringing sensation. That tells me that maybe it's coming from the hearing cortex. So that very first symptom is one of the most important things. If there's no such a thing, or if the patient is too young to describe that, then if it's a motor seizure, if there's any difference between how the movement goes in the right compared to the left. Another thing, if the patient is able to answer questions or talk, or is aware during the seizure. That's a very important one. If there's any head deviation to the left or to the right, if there's any eye deviation, if the patient gets very stiff, if the stiffening is symmetric, meaning that the two arms are extended in the same way, or if one arm is up and the other one is down. So all those details tells me a little bit where the seizure are coming from.
Okay, good to know. Thank you. I think we have time for maybe one or two more questions, maybe. So next question says, my child only has absent seizures and they aren't very often. Do they still need to go on seizure medication?
The answer is yes. And the reason is because, well, I don't know especially depending on the age of the child. Some children with a childhood absence epilepsy, they may be going to school and they may having these little moments of disconnection through the school setting, and they may be losing some learning potential there. If that's the case, certainly medication should be considered. Then the other big one is if the patient is an adolescent and is looking for a driver's license, even a 10-second disconnection can cause a terrible accident if someone is behind the wheel. So those patients need to be on medication. The other thing is if we have teenagers, more than children, starting with absence seizures, the odds that they may eventually, if we leave it untreated, have a bilateral tonic-clonic seizure or a more severe motor seizure are quite high. So I tend to treat unless the family are very hesitant to it and they tell me, and it's a young child and the child is doing fantastic in school in spite of their absence, I may hold on, but I would rather treat.
Okay, sure, that makes sense. We have a few more questions, but maybe let's just go with one more just for time's sake. So sorry, I'm just trying to find the right one. So what if they say their feet go tingly before they have a seizure? Where would that be coming from?
The feet?
Mm-hmm. Yeah, their feet.
Their feet, well, depends if it's the right or the left. That could come from the inner part of the sensory cortex that is located in the middle. Typically, the foot, it's in the middle of the brain side. Mm-hmm. So if it's in the right, would be the left, and if it's in the left, would be the right. So that could be one possibility. Okay. That would be the most accurate possibility, actually. That it would be in the inner part of the frontal lobe or the motor cortex.
Okay, good to know. Okay, so it looks like that's all the time we have. So thank you to everybody who has watched and also who has submitted questions. If your questions were not answered, please talk to your doctor, or your neurologist, or epileptologist and ask them those questions when you do see them. And thank you so much, Dr. Andrade, for joining us. We can't say thank you enough. It was really, really informative and super, super interesting. I know, at least for me, and I'm sure for our family. So thank you again.
Thank you. And also visit our website. Many of your questions may be answered there.
Yeah, absolutely. It's definitely a great resource. Lots of information there about medications and treatment options and the team. So definitely check that out for sure. All right. Well, goodbye, everyone. Thanks for tuning in.
Thank you, Jamie. Bye.
Thank you. Bye-bye.